Welcome to QI Connect, our third session for 2020, our 63rd session since we began, on what is a beautiful sunny day in Scotland for colleagues joining us from up here. QI Connect provides an opportunity for colleagues across health and social care to learn from international leaders in the fields of improvement, innovation and integration. So welcome to QI Connect. Next slide, please. This is our first session on our brand new platform, Microsoft Teams Live Events. This will be a little bit different from our previous sessions on WebEx, and in just a moment I'm going to pass you over to Jess to tell you how it works and how to use the Q&A function to submit your questions today for our speaker Michael West. So this is our first time using MS Teams Live. We've done lots of preparation to familiarise ourselves, but we fully expect something to take us by surprise. But we can't think of a better audience to be using this platform with for the first time than one of improvers, as we know you'll be patient with us as we learn and continuously improve. Over to Jess.
Thanks very much, Ruth. I'm just going to take you through some housekeeping notes for this session, in the first one in MS Teams Live. So you'll see already that you will not be able to use your mic or camera in a live event, but you will still be able to see and hear the presenters. At present, it's not possible to interact with other attendees via chat, but what you can do is you can upvote any questions that you see in the Q&A that you particularly like to see put to the speaker. I'll come to the Q&A function in just a second. So please use the Q&A function to submit your questions for Michael West. These will need to be moderated in advance, so it may take a minute or two for your question to show up in the live meet chats. And this session will be recorded, and by taking part you consent to this, and a recording of this session and resources covered will be made available following the session date. So to use the Q&A function, if you look at the top right of your screen, you'll see there's a little speech bubble logo with a question mark in it, and when you click on that, that will bring up the Q&A panel. Which will look like this. So please use the text box at the bottom to submit your questions. Any questions you submit will appear in your My Questions tab, and then once they've been approved by a moderator, they'll appear in the main Q&A. And if you just bear with our moderators today, it may take a wee minute or two for them to get to your question if it gets quite busy. You can upvote any questions that you particularly like by clicking the like button. So that's quite a nice wee feature. And there will be a summary of any resources covered in the course of the session, along with the recording afterwards. And I'm just going to pass you back over to Ruth.
Thank you, Jess. So as well as staff from a wide range of health and care services in Scotland, we're joined today by colleagues across the world, and we now have over 1,300 organisations who link in, not all live, and that includes 89 universities and colleges. Next slide, please. And of course, QI Connect has a truly international audience. We have 65 countries now represented in our QI Connect community. Next slide, please. A big shout out to the QI Connect team who work so hard behind the scenes to make sure this runs smoothly. Next slide, please. And not only do we have a brand new platform, we also have a new QI Connect Twitter account. So please, we would encourage you to tweet as you learn, use the QI Connect hashtag and tag us in @ConnectQI, as you can see on the screen. And please do give us a follow on this new Twitter account. Next slide, please. So today we're celebrating across the world World Patient Safety Day, with a focus this year on staff safety and its inherent link to the delivery of safe care. And I'm delighted today to introduce Michael West, who is a senior visiting fellow at the King's Fund and a professor of organisational psychology at Lancaster University. He's had a particular research focus about the connection between leadership, team working and patient safety. And Michael, I remember your work informing my practice when I worked south of the border down in England over 13 years ago. So I think it's fair to say you've been providing thought leadership on this topic area for quite a while now, as evidenced by the fact that you have at least 20 books to your name and over 200 published papers. So I think we'd struggle to find anyone better qualified to talk to our topic today of the courage of compassion for high quality health and care. So without further ado, it is my pleasure to now hand you over to Michael West.
Thank you, Ruth, for the very generous introduction. It's an enormous honour for me to be invited to speak to all of you on this QI Connect global webinar. And I want to say also a particular thank you to the amazing QI Connect team in Scotland who've just been brilliantly supportive in preparing for this webinar. And a thanks to all of you who are watching for giving me the privilege of your attention. I'd like to reflect on these last 6 months that we have been going through, a shared humanity around the world experiencing tragedy, fear and uncertainty, and particularly in health services and in social care services, and reflect on what lessons we can draw from this time. I think one of the most important is a positive lesson. We've seen the most extraordinary levels of innovation at pace and scale in health services, in social care services, and actually in the amazing collaborations across health and care boundaries, as well as with other sectors. We've also seen, particularly in Europe and North America, the disproportionate impact of the pandemic upon those in minority ethnic groups, and the disproportionate impact and tragic impact on staff in health and care from minority ethnic groups. And that's really drawn attention to the long-standing problems of discrimination and racism, and how discrimination and racism have such a profound effect on people's health and their whole lives indeed. We've also seen, I think, great team working being demonstrated in various places, real camaraderie, support and innovation, and lots of focus on learning and innovation and supportiveness. And we've seen also, I think, an outpouring of compassion around the world. Compassion from staff working in health and care to those that they're caring for, to patients and people in their communities, from staff members to each other to support each other through what's been an enormously difficult, challenging time for people working in key roles. And also from our communities, an outpouring of compassion from people in our countries and our communities towards those working in health and care. And I think compassion has been a defining value during this period. And I want to reflect, first of all, on how important compassion is in our health and care services. I've been particularly influenced in recent years by reading the research about the impact of compassion on healthcare outcomes. And I just want to show you a few key points from a wonderful review of this literature by Tresiak and Mazzarelli, two doctors working in the United States. And if we can go to the first slide, please, Jess. And to the first set of bullets about compassion. Thank you. And what this review tells us is that I'll only pick out a very small number of points from this review, most of which are randomized controlled trials, or they are meta-analyses of multiple studies. But we see that when anaesthetists are prompted to visit patients prior to surgery and to be compassionate in their interactions rather than giving sedatives, that patients are calm but not drowsy, as opposed to when sedatives are given, patients tend to be drowsy but not calm. And also those compassionate interactions have an impact on pain post-surgery, associated with much lower requirements for painkillers and a much shorter length of hospital stay. One randomized controlled trial that I found particularly striking was a study of patients with an early diagnosis of likely terminal lung cancer, and patients were randomly assigned either to early palliative care or to normal early cancer care. It was a study actually of the impact of early palliative care on quality of working life. And what it found, a great surprise to the researchers, was that those assigned to the high compassion early palliative care condition survived on average 30% longer. And we see similar striking findings in long-term conditions like diabetes and HIV. And also what this review shows is that, contrary to what most clinicians think or feel, compassion doesn't significantly affect encounter length. Moreover, when clinicians are prompted to be compassionate in their interactions over, say, a 2-week period, that appears to have a significant effect on their own levels of depression, anxiety, and distress. They are much healthier mentally as a consequence of being compassionate. We also see that compassion is associated with lower costs in healthcare, and the list goes on. And I think one of the striking findings is that compassion is more powerful in its effects than aspirin in relation to heart attacks and the effects of statins on 5-year cardiovascular risk. Compassion is the most powerful and effective treatment there is in healthcare. And we also know from neuroscience research that empathy and sympathy are associated with the activation of pain centers in the brain, because we're mirroring distress, whereas compassion is associated with the activation of reward centers in the brain, because we're hardwired to be altruistic and compassionate. The challenge for us, I think, is how we create the conditions in our organizations where those we lead will deliver high quality, continually improving and compassionate care. How can we create the conditions where they will be compassionate? And the answer to that, of course, is it's about the culture of our organizations. And culture is a consequence of all of our behavior every day. Every interaction by every one of us every day shapes the culture of our organizations. How warm we are, how kind we are, how irritable we are, how cynical we are, how compassionate we are shapes the culture of our organizations. But the role of leaders is particularly powerful. What leaders pay attention to, what they focus on, what they talk about, what they measure, what they model in their own behavior, tells us what it is they value. So in order to create cultures in health and care of compassion, our leaders must model compassion in their leadership. And let's think about what compassion means. There are 4 key behaviors. If I'm to be compassionate to another person in distress or pain, first I have to be present with the other person, psychologically present, emotionally present. Nancy Klein uses a wonderful phrase, listening with fascination. Second, I have to seek to understand the challenges or the causes of the distress, ideally through a dialogue with the other person. And third, I have to have an empathic, a feeling response, feeling their distress, because that gives me the motivation for the fourth element of compassion, which is helping or serving. So leaders must embody those four behaviors in their leadership. Can we go to the next slide, please, Jess? So we need leaders to model attending to staff, seeking to understand the challenges they face, empathizing with them, and then helping them. And this is doubly important because certainly across all of the nations where I've looked at data, what we saw back in December, January, was staff under enormous levels of pressure, high levels of stress, sickness absence, intentions to quit, vacancy rates, shortages of staff worldwide. And then the pandemic struck with all of the attendant additional stresses and fears. So our leaders must be compassionate to create compassionate cultures. And those four behaviors, we know from the leadership research over the last 60 years that those are the four behaviors which are critical to effective leadership also. And that's no coincidence, because they're the behaviors which help us to connect with the other person. And actually what we see is that those behaviors are associated with the outcomes that we desire in health and care. In England, they've been running a national staff survey for 15 years with over 250,000 responses from staff every year. And that's enabled the exploration of the link between staff experience and the outcomes for hospitals, mental health institutions, primary care, and so on. And we're able to do the most sophisticated analysis on that data. And what it shows us, if we go to the next slide, Jess, please, is that staff experience is the most important determinant, predictor of the performance of health and care organizations. Where staff report high work pressure, patients subsequently say they're not treated with respect, they're not treated with dignity, they're not given the privacy they wish for, they're not treated with compassion. When staff report high levels of work stress, poor health and well-being, we see subsequently in those organizations significantly worse care quality, lower levels of patient satisfaction, significantly worse financial performance, and in the acute sector, higher levels of patient mortality. These are the most, staff experience is the most powerful predictor and determinant of the performance of our health and care organizations. So compassionate leadership is fundamental to ensuring high quality, continually improving compassionate care. But I want to emphasize that compassionate leadership is not about soft cushions and scented candles. If you go to the next slide, please, Jess. Compassionate leadership is about a strong focus on people and on purpose and performance. It's about good performance management, and it's not about taking an easy consensus way forward. When Nelson Mandela, I think an amazing role model as a leader, when he was released from Robben Island in 1990, he went against the wishes of the vast majority of his followers who were prepared to go to war against the apartheid regime. He committed to negotiation and reconciliation in a successful quest to achieve a relatively peaceful biracial South Africa. And compassionate leadership applies not only to individual leadership, but also to our institutions, that they too behave with compassion by attending, understanding, empathizing, and helping. And let's probe a little deeper into this concept of compassionate leadership. If we have the next slide, please, Jess. Compassion in health and care is ultimately for the people and the communities that we serve. So in addition to those four behaviors, it is fundamentally about being effective as a leader in health and care. And that means leadership that ensures clear direction, the alignment of people's efforts around that clear direction, so their efforts aren't being dissipated on unnecessary activities, wasteful activities. And it's about ensuring commitment of people through encouraging trust and motivation. And if leadership is not inclusive, it's not compassionate. And I believe that given all that's happened in the last 5 months, 6 months, now is the time when we must all as leaders work to create inclusive cultures in our health and care organisations. And through that, I believe we can transform society. In many organisations, those working in health and care constitute 1 in 9, 1 in 10 of the working population. If we create inclusive cultures in those organisations, we transform the wider society. And it's about, as a compassionate leader, encouraging collective leadership where everyone feels that they have leadership responsibility. It's astonishing that in so many countries where the health and care workforce is probably the most skilled and motivated in any area of industry, that we manage them through command and control, top-down hierarchies, rather than encouraging collective leadership. And compassionate leadership is also about working supportively across boundaries, working with other teams, with other directorates, with other departments, with other organizations in a supportive, compassionate way, always asking the question, how can we help you be effective so that you can deliver, we can together deliver for the people and the communities that we serve. I think the other important point to make about compassionate leadership is it must be informed. It's about understanding what are the core needs of people in work, the staff that we lead. And I've had the privilege over the last 3 years of working on 2 inquiries into the mental health and well-being of doctors across the United Kingdom and the mental health and well-being of nurses and midwives across the United Kingdom. And it's clear from those that we have been failing to meet the core needs of our staff in the workplace, with a consequent negative impact on their health and well-being, and a negative impact also on quality and safety. I believe that the evidence is utterly convincing that if we don't provide high quality, continually improving and compassionate support for our staff, they will not be able to provide the high quality, continually improving and compassionate support for people and patients in our communities that we aspire to. So we must understand their core needs, and the model we've used in our work in these inquiries over the last 3 years has been a model, well-evidenced model by DC and Ryan, an intrinsic motivation theory model. If we go to the next slide, please, Jess, and we've called that the ABC of core needs at work. People need first to have a sense of autonomy and control in their work, to feel that they have influence and that they can shape the way work is done in the best interests of patients and their own well-being, rather than feeling just like resources which are pushed around and directed. It's also about having working contexts that feel just and fair, and issues of discrimination are clearly contrary to that. Because when we work in just and fair environments, it gives us a sense of control, and having a voice gives us a sense of control. And it's also about basic work conditions. We've seen in our work over the years that doctors, nurses, midwives, allied health professionals, social workers are often placed in working conditions, particularly when they're working on night shifts where they don't have access to nutritious food or good hydration or places to rest. And we've listened to harrowing stories about people having to sleep in petrol stations on their way home because they're so tired after successive night shifts, or not having time just to go to the toilet in the course of a shift at work. And these are our basic biological needs, and when we can't satisfy them adequately at work, it takes away that sense of control, or not having control over work schedules and rotas. And it's also about belonging. I think the need to belong is probably, after our biological needs, the most important human need there is. We're more likely to die from the effects of loneliness than we are from the effects, for example, of obesity or smoking. And belonging is about, we have very clear data that working in a team where I feel cared for and I care for those I work with gives us a really profound sense of well-being. It's a buffer against the stresses of the work we face. It's a buffer against the organizational tensions we face. And all of our research over the last 30 odd years has shown how protective team working is to mental health and well-being, and how significant it is in terms of ensuring that we are providing high quality care. That's about well-functioning teams with clear objectives, good communication, and supportive, cohesive climates. And it's about working in compassionate cultures with compassionate leaders. And third is the importance of having a sense of competence or contribution, that particularly in health and care, we want to feel that we're doing a good job, that we're offering high quality compassionate care. And we encounter many examples of moral distress where health and care workers feel that they're not able to deliver the care and support that they feel is right and appropriate. And usually that's because of what I call chronic excessive workload. So many people working in health and care are trying to manage chronic excessive workload. And it's become, I think, like the pattern on the wallpaper that we no longer see. It's the #1 predictor of patient dissatisfaction when staff have chronic excessive workloads. It's the #1 predictor of staff stress. It's the #1 predictor of staff intention to quit. And it's also related to cardiovascular disorders, to cancers, addictions, diabetes, depression, and even family breakup. So we must address these issues. One of the organizations I've been working with, East London Foundation Trust, a large mental health learning disability organization, regularly reviews with its staff what work activities they would get rid of or reduce. They've cut out 85% of clinical audit activities, yet they're still rated by the National Audit Body as outstanding in terms of quality of care that they provide. And there are other ways of dealing with chronic excessive workload: better team working, uses of new technology that we've seen during the pandemic, and also changing the relationship with patients and communities so that we capitalize on the community resources that can support patients and communities. It's also about competence and contribution, about having good supportive supervision, and also ensuring that we're giving people opportunities for continuing growth and development through new challenges, through training and development, and so on. I've emphasized team working continually so far, and it is hugely important. And I want to mention briefly, if we go on to the next slide, please, Jess, the importance of rebuilding teams during the pandemic. And I'm not going to go through all of these, but key is having a clear sense of purpose in our work and reuniting around a clear sense of purpose. It's also about making sure that we value diversity. Diversity, after all, is fundamental to effective teamwork. Multidisciplinary teams are more productive, more innovative than unidisciplinary teams. And it's about managing task-related conflict effectively together. And I think particularly at this time, it's enormously valuable to take the time to celebrate success together and to to appreciate people's contributions, to recognise their contributions so that we build a sense of cohesion, particularly when we're working remotely. But I particularly want to emphasise the importance of taking time out to reflect. So we've seen during the pandemic teams going into huddles, quick huddles, to review and reflect and learn and bring about change. And I and my colleagues began studying hard-pressed teams in health and care in the early 1990s, and we've continued ever since. We were interested in the extent to which teams took time out on a regular basis to prepare, for example, for a shift on a ward during the day, or for a social work team to take time out for a day each month to review their objectives, what they were trying to achieve, how they were going about it. Community mental health teams meeting fortnightly to review cases together. And what our research has demonstrated, in line with many other researchers now around the world, is on the next slide, that teams that do this are on average much more productive and much more innovative than teams that don't. Indeed, a recent meta-analysis of 49 separate published peer-reviewed studies showed that teams that take time out on a regular basis to review, to debrief, even if it's 15 minutes at the end of a shift on a ward, are on average between 35 and 40% more productive. Remember, that's based on 49 separate published peer-reviewed studies combining the data. And I think there's a general truth here. Particularly during the pandemic, those of us who have been able have spent more time in gardens, in nature, and benefited from the peace and the stillness, or through practices of meditation, mindfulness, benefiting from that stillness and peace. And as I say, we see the same phenomenon in teams, and we find the same in organizations in terms of their cultures. The more times we have for being still and peaceful and reflecting, the more productive and innovative and creative we are. So I can, I think, summarize what I've been saying today on the next slide by saying we have to create psychological and even physical safety for our health and care staff, and that's about compassionate leadership and effective team working. That's how we create trust and the conditions for innovation. It's about having clear shared direction, space for reflection, learning rather than blame and fear, the importance of frequent contact with each other, the importance of valuing diversity and difference, and working through task conflicts in a positive, transparent, ethical way, and showing mutual support and compassion, and as leaders, showing humility. But I want to finish by saying I think the most important challenge that we face as leaders, if we're to have the resilience and capacity to model compassionate leadership, we have to have the courage, first of all, to be self-compassionate. The next slide, please, Jess. That means paying attention to ourselves. It takes courage. Understanding the challenges we face in our work lives and in our lives generally. Caring for ourselves as individuals in this existence, and then taking intelligent action to help ourselves in order that we can be the best we can be, and stay close to the core values that give our lives meaning, like compassion and courage. And that enables us then to have deeper and more authentic connections with all of those we lead, indeed all of those we interact with in our lives. So it begins with self-compassion. Thank you for the privilege of giving me your attention. Ruth.
Thank you. Thank you, Michael, for that superb and really thought-provoking presentation. We're getting lots of questions coming in, but we will start today with our guest questioner, who is Jo Matthews. She is Head of Improvement Support and Safety in Healthcare Improvement Scotland, and her role includes responsibility for the Scottish Patient Safety Programme. So very appropriate that she's our first questioner on this today, World Patient Safety Day. Jo, over to you.
Thank you, Ruth. And I would just echo your comments there. Thank you, Michael, for such a powerful and thought-provoking session. Your call to action about now being the time to create those inclusive cultures through compassionate leadership, I'm sure will resonate with many listening today. You talked about psychological safety and that being central to compassionate leadership. Reflecting on the COVID context health and social care teams across the world are now operating in, what advice would you give for both building and maintaining psychological safety within a remote and digital environment?
Thanks, Jo, and it's really good to talk with you, and thank you for your kind comments. Face-to-face contact is really important for us because most of us are hardwired to read each other's faces. There are exceptions, of course, but most of us are hardwired to read each other's faces and to pick up the subtle cues that tell us it's safe, this person means well to me, there is warmth and love. And so when we're not able, and also to read bodily gestures as well and orientations. So when we work remotely, of course, we don't have that richness of information. So I think it's really important in the meetings we have remotely to make sure we're having perhaps more meetings than we might normally have, and to build in space in those meetings for Slack time, just to chat at the beginning, maybe at the end, about, you know, how was your weekend, your day off, how is the family, you know, what's been lovely for you in the last 24 hours, and the space to share humor, you know, to be warm and funny with each other. The space also to celebrate success and appreciate each other, to communicate that we value each other's contribution wherever we have the opportunity to do that. I know that as we've been preparing this QI Connect event, one of the things I've appreciated about the team doing all of the work has been the supportiveness and appreciation and humor that has been expressed over this remote medium. And I think it's also important that as team members, we check in with each other. We may want to buddy up in pairs, but we check in with each other and make sure each other is okay, so that we're providing that social support. And I think, you know, it's little gestures sometimes, people coming to meetings together and sharing, as it were, a time when they have coffee or tea or sweets or cakes. And also I think it's about trying out things to see what works and reflecting how is this working, to make sure that we continue to develop new and improved ways of doing things. If ever there was a time for quality improvement in how we connect, this is it. Trying out new ways of meeting together so that we affirm our sense of belonging, our oneness and our support for each other during this hugely uncertain time.
Thank you, Michael. Next slide, please. So please do submit your questions through the question function. There's lots that have been coming in, but also please do keep voting on which questions you most want to see asked by using that like button next to the question. So I will be guided by the votes in terms of which questions I put to Michael, but I may also use Chair's prerogative to pick some questions lower down the like list. And also sometimes there's a question with a lot of votes that's asked early on in the presentation that Michael's then picked up. So I will jump over those ones. So the first one we have with the most votes at the moment is from Anonymous, and it is: how can we improve compassionate leadership in non-clinical roles and national bodies that might be tempted to think compassionate leadership is only for clinicians and frontline staff?
So I think That's a wonderful question, and hugely important, because, as I mentioned earlier, I think compassionate leadership is about institutional compassion as well, because national organizations have such a big impact on the culture of local organizations and behaviors. It seems to me vital that we communicate with national leaders and the executive teams of our organizations and boards and get their support for changing culture. And their support, I think, can be won through providing the research evidence of the links between compassionate cultures and the outcomes that we seek: high quality care, staff well-being, financial performance. And the evidence is clear. Second, I think we have to make it clear that culture is not like a piece of pizza. We have one bit of culture for how we deal with patients or people in the community that we're serving, and another bit of culture for how we deal with staff, and another bit of culture for how staff behave towards each other. Culture is like an ocean, and it is one medium. And if we have one element of our culture that is not compassionate, for example, national leaders or board members, then that, through processes of emotional contagion, permeates out into the wider culture and dilutes, weakens the sense of compassion. I've had the privilege over the last 6 or 7 years of presenting continually to leaders in national organizations and boards about the evidence, and I'm heartened by the fact that with persistently dripping out the message, it does bring about change. In Scotland, we see that compassionate leadership is at the heart of the Scottish Government's approach to leadership across all public services and government, and similarly in other parts of the United Kingdom and in other countries as well. So I think it's about having the courage of persistence and recognizing the implications of your question, that we must achieve a comprehensive change in culture. Thank you.
Thank you, Michael. The next question is from Nat Moore, who is asking that they would really like to hear your thoughts about how we might support leaders to manage their anxiety towards collective leadership, and manage that anxiety in terms of moving away from a command and control approach.
I think this is a very wise question, because I believe that one of the main reasons that people adopt a command and control approach, which I think is an easy opt-out compared with compassionate collective leadership, is because they lack confidence in how to lead effectively, and they revert to a command and control directive approach. I think that the way we build people's confidence is through experience rather than through intellectual argument. And we know from reviews of literature on training people to be compassionate as leaders that actually it's eminently possible and very successful to provide that training, to provide the training first and foremost, to learn to be present with those we lead, just to be present with them in this moment. And when we interact with each other in that present, self-aware way, my experience is that's intrinsically rewarding. And through practicing being present, doesn't mean being perfect, and practicing listening rather than directing, what we discover is that our interactions are enriched and our ability to lead is enriched. So it becomes a self-reinforcing process. We also learn from those we listen to and lead what it is that would help them do their jobs more effectively, what obstacles they need to be helped to remove, and what resources they need to be helped, they need to be given in order they can do their jobs effectively, whether it's staff, equipment, training, or whatever. So I think that the way we encourage people to have the confidence to be collective is to help them practice these skills through the training that we provide. And what I'm very much involved with at the moment, particularly with the Welsh National Health Service system, is developing materials to ensure that leaders across the whole of health and care in Wales over the course of the next 10 years are developing compassionate leadership. And I know that colleagues in Wales would be very happy for me to share those materials with you if you would be interested.
I think that would be really helpful, Michael, and it links to this issue about resources. Is a question that somebody's highlighting. Now that we're working much more from home online, and some of us are permanently at home online at the moment, they're wondering if there's any current research on the organisations and teams that are particularly successful in promoting staff wellbeing within this context. So you've highlighted some resources there about Wales. Are there any other areas you would encourage us to look at?
Let me check the question, Ruth. So you're asking about, are there particular organisations which provide good examples?
Yeah, of working from home online when folk are remotely working, and it might be that it's too early on and the research is going to come out over the next 6 months, but people are wondering, are there organisations who are good at this that we should be looking to?
So what I've seen is that there are some organisations that have been very good about checking with their staff how they're coping in these current circumstances very quickly. They're doing pulse surveys on a regular basis every 4 to 6 weeks to check on how things are working out for their staff, and then intervening to bring about change. Northumbria Healthcare Trust is one good example. Berkshire, a mental health and community trust, is another. Berkshire Health is another good example, and Royal Bournemouth and Christchurch is another good example. I think we haven't yet seen the, I suppose, accumulation of wisdom about what's working well, but those are organisations that I know that have been implementing change in response to what staff are requiring, and seeing positive effects on staff well-being and satisfaction over the course of the pandemic, rather than declining well-being and satisfaction.
Great, thank you. I'm going to use Chair's prerogative to jump to one here from Chris Weatherburn, who is highlighting that this issue about teams taking time out and meeting together to debrief, and is saying, is it not the case that a well thriving team potentially finds it easier to take this time out? In a team with chronic overload of work, it can be much harder to find this time. So I was looking for your reflections on that, Michael.
Yeah, I think it's absolutely right. I mean, when you are spinning the hamster wheel, and I see it almost as a kind of pathology, not only of healthcare organisations, but organisations generally, this pathology of overwork. We're spinning the hamster wheel, and then the pressure gets greater, and the only response we know is to spin it faster. And that just gets more and more exhausting, and in the end is self-defeating, because people get very ill and are absent from work or worse. So yes, it's true that those that are thriving have the confidence to take time out. But we've looked at this issue, for example, in primary healthcare teams that have very poor ratios of doctors to patients, or are working in very poor premises. And we find consistently that those that do have the courage to take time out, to start to take time out, do experience transformations in the well-being of the team. So what we've been trying to do is to communicate the message about, it's not just desirable to take time out, it's actually fundamentally necessary to work well as a team to do that. And to get this understanding and message shared more widely across our health and care systems. I mean, the statistic I quoted to you, Chris, 35 to 40% more productive when you take time out, is just so clear, and that's across sectors as well, and we see it particularly in the health and care sector. So for me, it's almost a mission as it were, to proselytize about this and encourage that effective way of working. I feel passionately that we must be aspiring as a species to make work a joy. It's a sad fact that in the whole of Europe, only 17% of people say that they're engaged in their work some or most of the time. The other 83% seem to find work for the most part dull, boring, monotonous and painful. And work constitutes a huge portion of our lives. So I think it's the responsibility of all of us as leaders to help to create joyful work environments. We have so many examples in health and care of where that is the case. And if one can do it, then all can do it. So please join me in this mission.
Thank you, Michael. A lovely challenge to all of us to lead by example there. We have a question that's actually focused around patient safety, and in particular significant and adverse events review processes. And it's highlighting that there's an increasing incidence of second victim syndrome during the whole process. And do you have any suggestions around how we might mitigate this at a local level?
Yes, so I think it's a fundamental issue of how we create learning cultures rather than blame cultures. And again, I think that there are two levels where this occurs. There's the organizational level in terms of its processes and procedures. And it's clear that many cultures create a sense of fear and blame among staff. We found it was endemic among doctors and nurses. They were so afraid of making a mistake, of being blamed, of maybe being prosecuted by their professional body, of maybe being vilified in the press. We see examples of organizations that have deliberately set out to create restorative learning cultures. Mersey Care, another mental health community organization in England, has worked on creating restorative cultures where the focus is on learning, not on blame. And they've reduced their disciplinary procedures by about 86% over recent years, saving millions of pounds in the process, where instead of creating more victims when things go wrong, they are seeking to create learning and safety. The second level, it particularly applies that, is in the teams that we work in. That's the most immediate environment for people at work and the one which has most influence on their well-being and their growth and development. So it's about as well how we create psychological safety in teams in many of the ways that I've been describing so far. I really believe that we have much work to do to create effective team working in health and care. And many examples of great teams and really effective, cohesive teams, but too many examples of teams that are not clear about their objectives, don't meet regularly enough, don't have clear roles, don't communicate effectively. And that in itself creates a dangerous environment for patients and for staff. So I think there's an enormous amount of work to do to develop effective team and inter-team working in our health and care services to create cultures where people feel safe and supported.
Thank you. And we have one now from Arvind, who is one of our national clinical leads at Healthcare Improvement Scotland. This question made me smile. I think all of us can relate to it. How can we best be empathetic to people who are expressing views or scientific ideas that we think are wrong and harmful?
Yeah. So as I said, compassionate leadership is about being effective and inclusive. And I think there are two issues here. One is there are difficult people that we have in our organizations or our teams. I think it's really important, firstly, that when we find difficult people, we look at the context they're working in, because so-called difficult people are often difficult because of the context they're in. Dysfunctional teams work overload and they behave in inappropriate ways. The second is we have to give feedback to people, and because very often managers have opted out and not given clear feedback. We have to coach people to change their behaviours when they're behaving inappropriately. And if that's not successful, in the end, we have to compassionately manage them out of teams and organisations, because they damage the effectiveness of teams and organisations which exist to deliver high quality care. In relation to issues of discrimination and bullying, I think that we have to be very much clearer, very much earlier, and implement effective policies within our organisations, because bullying, certainly in some systems, is endemic. In the English National Health Service, it's well over 1 in 5 people report being bullied by colleagues or managers every year, and we need effective systems in place to address those. There's a broader issue too, I think, to recognise that I think compassion is about changing, reinforcing compassion is about changing the cultures of our organisations, cultures that become much more focused on connecting with each other, being inclusive, increasing a sense of belonging. And it's never been more important, I think, than in this moment for us to work together to create compassionate cultures, both because of the pandemic, but also because we're at a crossroads as a species. We have disconnected from each other, creating discrimination, otherness, national hostilities. It's never been more important for us as a species to work together to address shared challenges like a global pandemic or climate change. And creating cultures of compassion is about creating cultures of connection and inclusion. And I think now is the moment for us collectively as leaders to do that. Not only must we feel compassion for each other as a species, I believe, but we have to spread the notion of compassion to include other species and the planet as a whole, to ask the question, to attend, to be present with what we're doing on the planet, to understand the challenges that we're presenting the planet and the ecosystem, to empathize with the wider ecosystem of which we're a part, and to take action to make a difference. So I think this work of developing compassion and compassionate leadership globally is important, not just for health and care, but for all of us as a species and the planet that we are privileged to inhabit.
Thank you, Michael, and you couldn't have finished us on a stronger and clearer point that this is actually about the future of the planet that we live on. So I know I'm speaking for everyone on this call when I say a massive thank you to you for that insightful and thought-provoking session on this World Patient Safety Day. I wish we had more time. There are so many more questions there, and it's just been such a delight to be able to hear from you and your thoughts today. Thank you.
Thank you very much. Privilege for me.
Thank you. Next slide, please, Jess. So just in closing, to remind everyone, our next session, which is on Thursday, the 29th of October, is remaining on this theme of staff safety and well-being. And we're delighted to announce that we have Professor Andrew Gumley, who's a Professor of Psychological Therapy at the University of Glasgow, and Dr. Alistair Cook, who is one of our principal medical officers at the Scottish Government, presenting around wellbeing. We hope as many of you as possible are able to join us live for that. Next slide, please, Jess. And then also to remind everybody that the rest of our back catalogue is available online. You can enjoy it on our website, or you can visit our QI Connect YouTube channel. Please do take advantage. There's just a wonderful richness of resources here. So that concludes our session today. I think we've managed as well to go live on MSS Teams for the first time without any major hiccups. So I can almost feel the relief of the supporting team. Thank you everyone for participating, and we look forward to seeing you in October. Thank you all. Bye.